Thank you, Dr. Sodot, for inviting me to talk about the radiographic criteria for resectability of pancreatic cancer after neoadjuvant treatment. And basically, as Natalia just said, the modality of choice in patients with pancreatic cancer is CT, and we need them at the time of diagnosis. And in those subgroup of patients with borderline resectable disease or locally advanced disease, those patients that receive neoadjuvant treatment, we need them again at CT after neoadjuvant treatment, and as we all know, this is a critical point in time, as these patients are either referred to surgery or deemed unresectable if they have progressive disease. And the third scenario, as we all know, is a very common one, unfortunately, and it is the persistent appearance of a borderline resectable disease, and this will be the focus of my talk. So what are the traditional criteria that we look for response to therapy on CT? The first one is decrease in tumor size. And we're looking for over 30% in the longest diameter according to the RECIST, the response evaluation criteria in solid tumors. And this is the first and most widely accepted criteria. The second one is a decrease in attenuation, and we consider it to represent decreased vascularization of the tumor. And last but not least, obviously, is regression of tumor from vessels. And here we have a nice example of a tumor in the pancreatic body and tail, and we see it abutting the celiac axis, and after treatment it decreases in size, decreases in attenuation, and also moves away from the blood vessels. So for us as radiologists, we say decreased size, decreased tumor vessel contact, this is response to treatment, and indeed on pathology, complete pathological response is noted. So we may think that these criteria are good enough to evaluate pancreatic cancer after neoadjuvant treatment in response to the treatment. And indeed, there is some evidence that tumor vessel contact may predict resectability. This is work presented by Casinoto in radiology, and they looked prospectively at 47 patients with locally advanced disease, and they show that partial regression of the tumor contact with vessels actually predicted resectability. So even if there was still some involvement of the blood vessels, here it's the SMA, and as long as there was at least partial regression, there was a high likelihood of R0 resection. However, when they looked at the tumor size and the tumor attenuation, they noticed that the degree in change did not predict resectability. So then there is actually a lot more evidence that the radiographic criteria may not be so accurate after neoadjuvant therapy. And this is the Sentinel paper by the group from Andy Anderson. And they looked at 129 patients with borderline resectable or locally advanced disease. And out of these patients receiving neoadjuvant treatment, 101 patients had no metastatic disease after neoadjuvant treatment. And according to CT, only one patient had anatomic downstaging with decreased vascular invasion, and only 15 patients had a response according to RECIST. So that's again over 30% decrease in the largest diameter. So we're talking about 15 patients responding according to CT, but on surgery, we have R0 pancreatectomy for 81 patients. So you can see there's a big discordance here, and the authors conclude that even though radiographic downstaging is rare after neoadjuvant treatment, these patients should still undergo pancreatectomy after initial therapy in the absence of metastasis. And this is another study by Ferroni from MassGen, where they looked at 40 patients receiving FOLFIRINOX, and according to CT after therapy, only 12 patients were considered resectable on CT, and R0 resection was actually performed in 35 patients. So again, a big discordance. And these patients had decreased tumor markers, decreased tumor size, but there were no clear fat planes around the critical vascular structures. The pathologic analysis of these findings actually showed significant fibrosis and no viable cancer. So again, these authors conclude that after neoadjuvant FOLFIRINOX, imaging no longer predicts unresectability, and patients should be explored for attempted resection. So there's plenty more. I'm not going to wear you out. There's just another one that shows a decrease of arteriovenous involvement, not able to predict R0 resection or complete pathologic response, and another one that says the CT actually overestimates tumor size and vascular invasion after neoadjuvant treatment. So again, we're not so accurate after neoadjuvant treatment. And here are the challenges. So as we said, the traditional radiographic criteria are not applicable. This goes for tumor size, tumor attenuation, and probably the tumor vessel contact. And the thing with tumor vessel contact, as Natalia pointed out earlier, is this haziness around the blood vessels. And we know that this hazy attenuation or stranding could represent, like Natalia said, first of all, viable tumor infiltration. Secondly, inflammatory changes, either secondary to tumor obstruction or post-biopsy. And I think most importantly is fibrosis from the neoadjuvant treatment and mostly from the radiation. And we know that fibrosis levels are higher in patients receiving neoadjuvant treatment than those that don't receive it. And this is actually our biggest challenge. What about other modalities? So PET-CT shows some promise. It can detect metabolic response that we can see on CT. And it can detect occult metastases and avoid unnecessary surgery. Still, the NCCN recommends not to replace PET-CT for high-quality CT. There are groups looking at quantitative dynamic contrast enhanced MRI, hoping that it may differentiate fibrosis from viable tumor. Some groups are looking at dual energy CT. I didn't find anything about adenocarcinoma versus fibrosis post-neoadjuvant treatment, but some are looking at, there was one publication that differentiated chronic pancreatitis from adenocarcinoma, and still CT remains the mainstay of imaging. And again, the NCCN, as we all know, recognizes the limitations of imaging and recommend that even if there is no apparent tumor shrinkage, still, as long as there is no extrapancreatic disease, surgery should still be attempted. And just another thing I want to point out about the NCCN, not all of this, just the marked, is the multidisciplinary decisions. I think it's, we all know it's very important that we all sit together and that you use us and still try to get us to help you with your decisions. And another thing is that the NCCN recommends that the use of a radiology reporting template may be helpful, and I think we should all implement this. So to conclude, accurate restaging of borderline disease after neoadjuvant treatment remains an unsolved problem, and following the treatment, the radiologist should be primarily focused on evaluating for worsening of the disease, that will include resection, meaning new metastases, or worsening vascular involvement. And for my final slide, you have all noted that I put the CT and microscope together. And indeed, many times when I speak with the surgeons, I feel like you want more and more and more out of the imaging, and so do I. And sometimes I get to a point where I say, well, I don't have a microscope, so I asked my dear partner to create this image for me of a CT and microscope combined. Thank you.